through now. We are going to go through the high yield like drugs for the cardiovascular system, for the pharmacology. You have to know like the first lines for hypertension in general. So this is the first line for hypertension in general, and you may have a patient who had like hypertension and had a concomitant disease. The patient may have hypertension with heart failure. The patient may have hypertension with diabetes or hypertension with asthma. So the order of the drug you gonna give the patient may be different. You just may give a drug that will be beneficiary for like two things. May protect the patient, protect his kidney, for example, in diabetes, like ACE inhibitors. So you are gaining like two beneficiary stuff. First, you are treating hypertension and also protecting the nephropathy that is associated for diabetes. So this is the idea behind that. You have to just know the order of the drugs. Also, there are some kind of drugs which are contraindicated. So the patient may have higher heart failure, and decompensated heart failure. So the beta blocker are usually contraindicated in cardiogenic shock and used with caution in decompensated heart failure. But let's start first. Which are the first line for hypertension in general? You will have like thiazide diuretics and ACE inhibitor and ARBs, like used interchangeably. ACE inhibitor and ARBs. And thiazide diuretics, and the fourth is like dihydropyridine calcium channel blocker. You have dihydropyridine calcium channel blocker, non-dihydropyridine calcium channel blockers. The dihydropyridine calcium channel blocker like antihypertensive medication versus non-dihydropyridine calcium channel blocker, which are essentially cardiac medication used for arrhythmia. They will have more effect on the heart versus the dihydropyridine calcium channel blockers, which have more effect on the vessels. So this is the antihypertensive medications in general. So when you treat a patient with hypertension associated with heart failure, the order may change a little. So you may have diuretics as antihypertensive medication. It will get rid from the volume overload and at the same time treat hypertension. You will have like some drugs that have like anti-mortality in heart failure, so like the ACE inhibitor and ARBs and the beta blocker. But with when you use beta blocker in the heart failure, you have like three scenarios. If it is compensated heart failure, it's beneficial for you like to use beta blocker for heart failure. Also, you may have like decompensated heart failure. Is that allowed to use beta blocker? Yeah, the answer is yes. You may use beta blockers, but you have to be cautious when using it. And the third scenario is like cardiogenic shock. It's contraindicated to use beta blocker. So this is for the beta blocker. Also, aldosterone and antagonist here is like a drug that may cause like antihypertensive, and it also anti-heart failure measure. So and here is like a note is in heart failure there are angiotensin receptor blockers. There are some kind of drugs that have both ARBs and the neprilysin inhibitor. We will go through the neprilysin inhibitor further in this chapter. You may give the drug that combines both ARBs and neprilysin inhibitor. So sacubitril. This is a line of the treatment for hypertension associated with heart failure. Next, the hypertension associated with diabetes. First, as we have just said, the ACE inhibitor or the ARBs, they have a beneficiary effect like treating diabetic nephropathy and protective against that. They just protect from the progression of diabetic nephropathy, and at the same time, they are antihypertensive medications. So you have to make sure that to start with ACE inhibitor or ARBs in the treatment of hypertension patients having diabetes. It's allowed to use a calcium channel blockers and also beta blockers. But as you noticed, like beta blockers are the last kind of drugs because they can mask the hypoglycemic symptoms. So they knock out the sympathetic system. When you have hypoglycemia, the sympathetic system starts warning you of the hypoglycemia. They knock it out. So they are like the last line of drugs that may use with diabetes. And for the asthma, you may use ARBs, but as you noticed here, we didn't put like ACE inhibitor. So as the ACE inhibitor, you have to avoid that in order to prevent the confusion. Is that the respiratory distress or the dyspnea is due to the drug induced or asthma related. So in order not to put ourselves in this kind of confusion, it is um, safe to use a ARBs instead of ACE inhibitor in asthmatic patients. Also, you may use calcium channel blockers. So calcium channel blockers mostly is like neutral, not related. You can use them with hyperdiabetes. You can use them with asthma. So it's like whenever I got like, don't think about contraindication. You can use calcium channel blockers. Very common to be used. So thiazide diuretics can be used in asthma. Not relevant to any contraindication or stuff. So, and for the beta blockers, you have to do like choose like the cardio selective beta blockers. So, and as a non-cardio selective beta blockers, they gonna cause like B2, like the B2 receptors are like bronchodilatory. If you just knock out the B2 receptors, you are gonna cause like bronchoconstriction. So in asthma, you have to like to use like the cardio selective beta blocker. Hypertensive in pregnancy, just memorize very well like these four drugs: nifadipine, calcium channel blocker, methyl dopa, labetalol beta blocker, hydralazine like vasodilatory, and we're gonna expose its mechanisms. So nifadipine, methyl dopa, labetalol, and hydralazine. Very high yield to know these are the drugs that are used in pregnancy. This is like abbreviation humans love hugs. So nifadipine, methyl dopa, labetalol, and hydralazine. So and now we are going to go like an illustration. We are not gonna go into the very details of this, but you have to start at the center of this, like the drawing. You have like myosin phosphate plus actin. So the myosin and actin interactions, as you know, it is what causes contraction. So it is causes contraction. So it's gonna cause like vasoconstriction. So there are like two enzymes, myosin light chain kinase and the myosin light chain phosphatase. So these are the heart of our distillation here. So this is like the contracted state and this is like the relaxed state. So the myosin kinase, like the chain kinase, is gonna cause like contraction and the phosphatase is gonna cause like relaxation. So there are different kind of drugs that act like different kind of receptors that is gonna go at the end to cause either relaxation or gonna cause contraction. First, you know calcium is going through the calcium channel, and there are some kind of drugs here that will block this process. The calcium at the end is gonna activate the myosin light chain kinase and will gonna put our vessels in like in the contracted states. So it will cause contraction if we knock this receptor out and will not allow the calcium to go in. We are gonna cause like relaxation. So this is like amlodipine, clividipine, nicardipine, nifedipine, nimodipine, the different kind of calcium channel blockers. They will block the calcium. The calcium medium complex will not go through the details, but this will essentially put our state in the relaxed state. So this direction will gonna be stopped here. So we are in the relaxed state, and like this is the first. The second is like the GQ agonists, epinephrine through the alpha 1 endothelin and angiotensin 2 is like as you remember, these are like vasoconstrictor drugs: epinephrine, endothelin 1, angiotensin 2, and vasopressin. They will work through the GQ and will inhibit the phosphatase and will also go through the calcium, through the calcium will just stimulate the kinase. So will, at the contrary, will make our vessel, for example, like in the contracted. So this is the second stuff. So the third, the drugs that will act through the nitric oxide. So the nitric oxide also is, at the end is gonna go affect this core step. So you remember the drugs that will cause vasodilation will increase the nitric oxide diffusions. Like you remember that acetylcholine alpha 2 agonist, vasodilator, parasympathetic, bradykinin, cytokines, histamines, all kind of different kind of vasodilatory effect or the relaxation. So you have to group them together in your mind: acetylcholine, alpha 2 agonists, bradykinin, cytokines, histamine, like bradykinin, cytokine, histamine, like the inflammatory mediator, vasodilatation at the end or relaxation. With them is like alpha 2 agonists, like alpha 2 vasodilatory, and acetylcholine, serotonin. So they will increase like nitric oxide diffusion, and the nitric oxide is gonna increase like cyclic GMP. So the cyclic GMP will stimulate this way. It's like phosphatase, but we will stimulate this way. So we'll put our cells in like in the relaxed state. So the nitric oxide also through the also nitric oxide. So like there is like natriuretic peptide, actually natriuretic peptide, brain natriuretic peptides. So it's like act like natriuretic peptide receptor. Don't memorize this stuff, but if eventually also the same mechanism as nitric oxide through granulate cyclase and the relaxation. So, and our last thing is like epinephrine, prostaglandin, but here is like B2, prostaglandin, prostacyclin, phenoldiazepam. This is like vasodilatory stuff. So the phenoldiazepam, like vasodilator at the splanchnic, renal, different kind of stuff. We'll go through it in the next pages. Like epinephrine also through the B2 in the lung, and prostaglandin like relaxation. All of them like cause relaxation, but they are grouped together and they act like the GS receptor. And epinephrine and norepinephrine through the alpha 2 through the GI receptor. All this is relaxatory, and at the end, don't memorize the stuff. They will like trap calcium, so they will cause like relaxation. So they will trap calcium at the end. Like a lot of inhibitory steps, don't memorize them, but it will cause like like relaxation. But at the end, you have to know that the core of the drawing and the like group in your mind every drugs kind of drugs, the same drugs, and the like the where they do like work through the GS, the GI receptor, or the inhibiting calcium as we have said, or the GQ IB3 pathway, and acting eventually through the calcium or through the nitric oxide as the acetylcholine alpha 2 agonist as we have just said. So after we have gone through this drawing and the illustration, we are going to talk now about like every drug. So the nitrates, so no, like nitroglycerin, isosorbide dinitrate, isosorbide mononitrates, essentially the same. They like cause vasodilatation by increasing nitric oxide in the vascular smooth muscle. So increasing nitric oxide in the vascular smooth muscle, so increasing cyclic GMP and smooth muscle relaxation. As we have just said, the cyclic GMP will be increased due to guanylate cyclase converting GTP to cyclic GMP. So when this occurs, so eventually, as we have just said, there will be a smooth muscle relaxation, and the nitrates are peculiar because like dilate veins more than artery, and they cause like preload. So they are very beneficial in angina and acute coronary syndrome. You will dilate the veins. There, the preload on the heart will decrease. So you are not loading the heart with so much kind of amount of blood. So very beneficial. as you know, you have to just make sure that you understand they dilate veins more than arteries. So they are not primarily used in angina or acute coronary syndrome because like cause vasodilation of the coronary arteries. But you have to know that the main action of them is like a dilation of the veins and decreasing the preload, and this will be very beneficial in the pulmonary edema, of course, as well decreasing preload will like elevate the pulmonary edema. So this is the nitrates. So and when they cause like vasodilation, of course, they gonna be a reflex tachycardia. So essentially, you may just combine nitrates with beta blocker. You give nitrates associated with beta blockers to like manage the reflex tachycardia and the methemoglobinemia. Watch out for methemoglobinemia with nitrates. Hypotension, flushing, headache is very, very, very common. I've seen many cases that may complain with headache after taking like nitrates for acute coronary syndrome. The patient who have multiple attacks of coronary syndrome, don't give me nitrate because I have like headache with that due to the flushing, also flushing. And there's something kind of concept was called the Monday disease. So some people who may get like industrial exposure to the nitrates, they will get like tolerance to the effect of it. So it has as we have just said that nitrate have like a vasodilating action. So as they work continuously with the nitrate exposure, they are just habituated for that. But when they take the weekend off, this like habituation will wean off and the tolerance will wean off. And as they come back again at the Monday of the next week after their like weekend, they like the habituation is just not there again anyway anymore, and they will have like the side effect as you have just give them nitrates like tachycardia, dizziness, headache as I. So this you notice it is like the same adverse effect: headache, hypotension, flushing. Also you have to know like the nitrates are contraindicated in the right ventricular infarction, and on the contrary, in the right ventricular infarction we may even give like fluids. So in right ventricular infarction, it's like you have to give preload, not decrease preload, to just like stress like the right side of the heart to work. If you giving nitrates in right heart failure, very dangerous. As I've just said, on the contrary, you may even give fluids, not nitrates. Also, hypertrophic cardiomyopathy, contraindicated to give nitrates in that very, very high yield, and phosphodiesterase 5 inhibitor. So I had that drawing like phosphodiesterase inhibitor, sildenafil. It's like blocking this phosphodiesterase 5. So when you block this, there will be accumulation of cyclic GMB and like relaxation. So you are, and if you give like nitrate at the same time, you're increasing cyclic GMB, and you are preventing it from the other side from breaking down by sildenafil. So you are will be tremendous amount of cyclic GMB, very, very amount, very severe vasodilation. So don't give like sildenafil. So the patient may take Erecta or any pills for like increased sexual erection or so. You have to ask your patient for that. And the next group of drugs is a calcium